the implants is an organization of fibers, cells, vessels that is relatively deficient if we compare it to teeth. And it is very important also to realize that implants, different from teeth, are not one piece, but they are basically the implant and the abutment, and therefore the implant to abutment connection in modern implants, which are bone level implants, may be at the level of the crest, or below the crest, or above the crest. And also the adjustment between the implant and the abutment may also alter the health of the soft tissues. Furthermore, depending on the macro design of the implant, we may have abutments that are wider than the implants, or we may have abutments that are narrower than the implants. And all this is going to affect the disposition, the three-dimensional structure of the soft tissues. And therefore, when we try to set up or to build up the soft tissues around the dental implants, we need to have these things into account. We understand that the soft tissues around dental implants do have less vascular supply, since they do not have the vessels coming from the periodontal ligament. Also, they do not have horizontal fibers attaching to the titanium, because fibers cannot attach to titanium, and therefore the resistance to probing of these tissues is lesser. And all these things are going to influence our ability to reconstruct the soft tissues around the dental implants. So my presentation will have three small parts. One that will deal with augmentation of keratinized mucosa. The other one will deal with how to augment the thickness of the peri-implant's mucosal tissues. And finally, whether we are able or not to cover peri-implant dehiscence defects. Of course, the keratinized mucosa around implants is a topic that has attracted lots of attentions, and not only from the research point of view, but also from the clinical point of view. You see, this is a publication from 2017 that is basically a review of systematic reviews, because in this topic, probably there are more systematic reviews than original studies. But basically, the summarize of all these reviews and background papers is that there is always a significant association between the reduced amount of keratinized tissue and plaque of inflammation. However, we don't have evidence that the reduced amount of keratinized mucosa is linked with peri-implant bone loss. However, we know that there is always a higher plaque accumulation, gingival inflammation, peri-implant mucositis in those situations of lesser amount of keratinized tissue. And also this is coupled with discomfort to the patient when brushing, and many times with the need of additional work in the sense of visits from the patients or recalls. So in these circumstances, it is clear that when we place implants, mainly when people have lost their teeth long time back, the amount of keratinized mucosa is going to be limited. And therefore, when we place our restorations in these sites with minimal amount of keratinized mucosa, there is going to be movement of the peri-implant mucosal margin, there is going to be plaque accumulation, and there is going to be inflammation. And therefore, there is a need in many occasions to augment this amount of keratinized tissue. If we ask ourselves, what is the state of the art? The state of the art, as you can see, is the free gingival graft, without any doubt. It allows us to basically set up a base of keratinized tissue around the implants, and the surgical procedure is extremely easy, because basically it consists on a horizontal incision, basically soft split thickness dissection and basically an apically positioned flap where we can place on a periosteal bed a free gingival graft composed of epithelium and connective tissue. Basically, we need to adapt well the periosteal bed to the free gingival graft that we are placing, and basically the healing should be good because all the vascular supply comes from the periosteal bed. So with this very simple approach, we can deal with many situations where we can create stable amount of keratinized tissue around the implants. And this is particularly the case in posterior mandibular sites, where most of the time the area of keratinized mucosa is quite deficient. Is there an important impact of tissue augmentation in peri-implant health? This is a question that we tried to solve when our group, together with University of Zurich's group, tried to answer this question in a systematic review. So basically, we tried to evaluate all the studies where in situations of deficient keratinized mucosa, grafting has been compared with no grafting. And clearly, if we look at the primary outcome, which is inflammation, we readily see that there is a greater improvement significantly of GI values when we place a grafting. And also there is evidence that the placement of a grafting improves also the marginal bone levels. And therefore, there is a gain by utilizing grafting. When we have evaluated alternative soft tissue substitutes to the free gingival graft in order to avoid the patient's donation of their own tissue, we have also looked at the possibility of using collagen matrices, xenogenic collagen matrices. And some years ago, we evaluated histologically the behavior of these matrices in mini pig gingiva, and we saw that the mechanism of action was very simple. These matrices behave like an inert scaffold, and the tissue from the vicinity ingrows inside the matrix and develops new connective tissue. If that tissue that comes from the vicinity, mostly from the lateral parts, is a tissue that will keratinize, it will develop keratinized mucosa, and therefore we can evaluate that it is highly predictable to gain between 2 to 4 millimeters of new keratinized mucosa by utilizing these matrices. And we have published clinical trials comparing the matrix to connective tissue grafts, and we have seen that in this indication the results are quite comparable in terms of the amount of new keratinized mucosa. However, of course, it's logical that the matrix will generate patients less pain and less surgical time. So whenever we have available tissue on the vicinity to ingrow the matrix, the placement of a matrix, once we have performed this split thickness apically positioned flap, becomes a highly predictable outcome, as you can see in this before and after situation. However, we need to understand that in many times we don't have lateral keratinized tissue to ingrow inside this matrix or this scaffold. So we have developed a variation of this technique where we try to fix the tissue that comes from the most apical portion. You see, this is a patient that we did lateral bone augmentation. We advanced the flap to cover the GVR procedure, and therefore we didn't have any keratinized tissue. So in the second stage when we wanted to augment that keratinized tissue, we did our apically positioned flap, but we placed a very small strip of the free gingival graft, basically to block the tissue ingrowing from the alveolar mucosa and to allow all the tissue coming from the sides. So you see the fixation of this small strip from the palate, and of course the end result is very favorable because by blocking the tissue coming from the alveolar mucosa, we allow more amount of newly keratinized tissue, and you can see the nice amount of keratinized tissue that we can generate. This, of course, can be applied to single teeth like the one I'm showing to you, but also this has been applied to large areas of vertical bone augmentation. And this is a report that I wrote together with Itz van Urban, that in this situation where large vertical ridge augmentation and advancement of the vestibular flaps, there is no keratinized tissue at all, and we can develop large areas of newly keratinized tissue by blocking the apical part by these strip grafts. So you see, we have dealt with augmentation of keratinized tissue. The state-of-the-art procedure is the free gingival graft. As an alternative, we may use collagen matrices or combination of collagen matrices and very narrow strips of free gingival grafts. So let's now discuss the augmentation in thickness of the mucosa. And this is very important in a completely different location. If the augmentation of keratinized mucosa is important in posterior mandibular sides, the augmentation of thickness is crucial in maxillary anterior sides, because when we lose teeth, we are going to lose the root prominence, and we are going to end up with a concavity in the contour that, if the patient has a high smile, that will develop in a very anesthetical outcome. So in these situations, mainly when we do immediate implant placement, we need to compensate not only the dimensional changes of the buccal bone plate, but also we need to compensate the loss of connective tissue. In this situation, completely different from the technique before, the augmentation is always done submucosal, and in most of the time without elevating the interdental papillas, but just developing envelope flaps in the submucosal area where we can stick in a gingival graft. You have to understand that when we do this kind of envelope flap procedures, when we close the flap, there is going to be quite a lot of pressure on top of the graft. So we need a graft that will maintain the thickness, will maintain the space to develop from a concavity to a convexity that will improve the emergence profile of our implant restorations. Can we, in the same manner, substitute these connective tissue grafts with collagen matrices? Well, we can, but we have to modify the technique a little bit in order to minimize that lateral pressure. And also we need to modify the matrix in also to make that matrix more resistant to lateral pressure. So you see this particular patient, and you see how we are going to do the technique. Basically, when we do immediate implant placement, we do a flapless approach. And as you know, we are going to aim to the palatal wall, and we are going to aim to place our implant about 1 millimeter below the crest, and always in the favorable, ideal, prosthetically driven position. Once we have placed our implant in the right position, we are going to do this envelope flap, and we are going to place the matrix in such a way that will withstand the lateral pressure of the suture. And this is going to be done also in combination with the placement of the provisional implant restoration. We are going, of course, to fill the gap with xenogenic biomaterial to prevent the collapse of the buccal bone, and then we will try to support the soft tissue and the matrix with the provisional restoration. This provisional restoration will be a little bit under contour to allow the lap of soft tissue to go in and to be maintained without collapsing. So let me share with you one clinical case where we can see that after a very careful extraction of the root tip, we basically follow the same protocol. First, we identify that we have buccal bone. It is important that we have an intact buccal bone plate, and then we place the implant in the ideal prosthetically driven position. And then once we have our implant in place, more or less 1 millimeter below the buccal bone crest, then we are going to do our submucosal envelope flap. We are going to basically try to adapt the matrix, and with this matrix in place, we are going to then fill with the xenogenic biomaterial the space between the inner buccal bone plate and the implant surface, and then we are going to adapt the provisional restoration in such a manner that the buccal soft tissue will apply the pressure on the provisional restoration and not on the matrix that we have placed. So basically with this approach, we can gain a nice thickness, and if the tissue is not very deficient, we can get very good ideal results, as you can see in the image. A good thickness of the peri-implant mucosal tissues and a good emergence profile of our restoration. With this approach, we have recently published a long-term prospective case series, also providing very nice results. So here you see another case with this situation. Immediate extraction. We evaluate the buccal bone. We place the implant in the ideal position. Then sometimes what we do is we develop this kind of butterfly forms by folding the matrix and creating a double layer with the matrix. And in this way, we can have basically 8 to 9 millimeter thickness that we can place it under the mucosa. And then, of course, you see how the provisional restoration will maintain the thickness without excessive lateral pressure. You see the healing, and normally the healing is very good. As you can see, this is the 1 week healing. And of course, there is going to be shrinkage. We get about 50 to 55% shrinkage. But since we normally over contour, the end result is usually quite appropriate. And you see the emergence profile that we get, and you see how we come from a full convex situation, not completely convex, but a good thickness and a good emergence profile of the final restoration.
Wow.
Nowadays, we even have new biomaterials that are able to withstand even better the volume, and these volume stable collagen matrices, they are cross-link collagen matrices, and for placing these, we have developed this other surgical approach where basically what we want is to advance the palatal flap in such a way that we don't exert any lateral pressure on the matrix when we close. And in this situation, we can be sure that these volume stable matrices are able to maintain the amount of volume that we have developed. You see this island flap approach, we go from coronal to apical split thickness flap, more or less halfway through, and then we come back from apical to coronal without connecting, of course, both incisions, but in order to allow the palatal flap to move coronally, and in that way to avoid the pressure when we basically suture. And in this manner, we have a big space under the suture that we can basically maintain with the matrix, and this scaffold effect will allow the ingrowth of tissue and will allow the thickness augmentation. You see how this so-called island flap allows the movement of the palatal flap in a coronal direction, and this will avoid any pressure. So you see, this is the suture. You see the amount of tissue that we are able to attain, and of course, with this amount of tissue, we can attain very good emergence profile in our restoration. So let me share with you in the last 5 minutes the last of the indications, which is the peri-implant tissue dehiscences. This is a much more difficult lesion to treat because you understand that we are not covering a root as later you will hear. Here we are covering an abutment, either metal or zirconium, and therefore there is no blood supply, and we cannot get any organic adherence of our grafts to the implant surface. As you can see, there are very few reports in the literature basically providing us with intermediate results. Some of the authors like Rocuccio gets to 80%, and of course you will hear Martina later on teeth, but they have published probably the best results ever published also on the treatment of dehiscences. Basically, the surgical approach is very similar. What we do is to create a pouch, an envelope flap that we apply a thick connective tissue graft. Here we cannot apply soft tissue substitutes, matrices, because there is no vascular supply at all, and therefore the matrix will dissolve without any tissue underneath. Here we need to utilize connective tissue grafts, and therefore we are going to develop these split thickness pouches that we can basically insert a large connective tissue graft. Let me share with you one of these particular cases where you can see the devastating aesthetic problems that these soft tissue dehiscences create. And as we have recently published, the most relevant cause of these lesions is the wrong placement of the implant, the buccally positioned placement of the implants, that therefore will create a very thin buccal plate, very thin tissue that with time will recede. In these situations, we always need to remove the crown. We have to place a really under-contoured abutment, and this under-contoured abutment will allow the tissue to give in. And once we have about 1 month with this very under-contoured abutment, then we place our thick graft normally from the tuberosity, and we try to create a very thick peri-implant mucosa that eventually will give in and will cover the newly crowned. Here we can do it with coronally advanced flaps or with submucosal pouches. Basically, the situation is the same. Here we cannot utilize matrices. We need to utilize connective tissue grafts, preferably from the tuberosity, which have thicker volume and is easier to create and develop enough tissue so that it will cover the abutment, and by changing the restoration, we can improve the aesthetics. So, ladies and gentlemen, I thank you very much for your attention in this presentation. We have evaluated three very different indications that we can utilize different surgical techniques and also different types of grafts, either autologous grafts or xenogenic grafts. And with this, I thank you again for your attention, and I am happy to answer any questions you may have. Thank you very much.
Thank you, Dr. Sanz. Fantastic presentation, as usual. So before we get into the technical questions related to the topic that you presented on, we are going to ask all the speakers a standardized question that is related to this COVID-19 pandemic that we're suffering. So let me ask you, in your opinion, Dr. Sanz, how do you envision that this ongoing pandemic will impact the way that we practice and teach dentistry in the future?
Well, I think here we need to evaluate it on short term and on long term. I think on short term, the only way we can return to normality is by science, by the development of a vaccine that basically will eventually do what happened with SARS. The virus disappeared. However, we shouldn't be so optimistic, because these coronaviruses mutate so much that probably the next generation will come sooner or later, and therefore the situation will come back. So that we need to change our approach to practice, and probably what we need to do is to enhance what we have been doing in dentistry for many years, which is good cross-infection control, good patient management, and probably we are the profession that has been better prepared to basically fight infectious diseases from patients in terms of cross-contamination. But I am confident that science will give us the solution, not governments or policies, but more related to scientific advances.
Thank you, Mariano. Very insightful. So let me ask you some questions that we got from the audience. Unfortunately, we got so many that we're not going to be able to answer all of them in 10 minutes. So I'm going to try to select the most relevant ones. One question that was consistently asked by many different people was related to the technique in terms of augmentation of pre-implant soft tissue thickness. And the question is specifically about whether you create a split thickness, full thickness, why and in what circumstances you choose one or the other.
Well, I always aim the split thickness. In that way, I will have double blood supply to my connective tissue graft or to the matrix. However, there are situations that the phenotype is so thin that basically, in order to avoid perforation, you have to go full thickness. But if I have any chance, I would always aim for split thickness.
Thank you. Now, I imagine that has to do with the supply that will get into the graft, whether it's
Sure.
an autogenous or substitute. So related to that, one consistent question also that I got from a lot of people was related to the stability of the matrices. How does it compare to autogenous grafts? How stable it is in the short and the long term, based on your experience?
Well, it doesn't compare. I mean, it compares. I mean, here we need to differentiate between a non-submerged application and a submerged application. When we do a non-submerged application, like for a soft tissue augmentation of keratinized tissue, basically we have seen and we have measured that the amount of shrinkage is basically between 50 and 70%. However, we have improved quite a lot if we block the apical migration with an autologous graft strip. But if you don't place the autologous graft split, basically, if you place, let's say, apicocoronally 9 millimeters, you will get 3 millimeters. So basically, you will get basically 2/3 of shrinkage. But also what we have seen in this application is that if a patient has good plaque control, 3 millimeters is enough to maintain long-term the stability of that peri-implant mucosa. But it is clear that irrespective whether you place a free gingival graft or a matrix, you need to have a very good patient compliance over the long term. And also it's very important, sometimes what you can develop depends a lot on the vestibule. If you have very, very shallow vestibule in the very posterior sides, it doesn't really matter whether you use an autogenous graft or a matrix. The mucosa will return, will come back. So you really need a minimum amount of vestibular depth and a minimal amount of lateral keratinized tissue to stabilize your matrix. Otherwise, the results will not be irrespective of what you use.
Thank you. So we have talked about keratinized tissue augmentation, thickness augmentation. One of the questions was related to the third dimension of the peri-implant phenotype, which is the supracrestal tissue height. What are your thoughts on the need of having a minimum amount of tissue thickness in a vertical dimension and the impact that it might have in bone remodeling and peri-implant health maintenance?
Sure. I mean, here the impact is more on the maintenance of peri-implant bone levels. And of course, if we don't have enough thickness, we will lose some bone because we need the ceiling of the soft tissues need a minimum dimension of connective tissue width. So if you don't have that, bone will lose. And if we are using bone level implants, and if we are using modern implants with moderate rough surfaces, we don't want any marginal bone loss. So that means that in order to avoid marginal bone loss, in order to have all the implant surface in front of the bone, you need to have a very good soft tissue seal. And that soft tissue seal needs a three-dimensional structure that needs to be maintained. So in that sense, I think it's more a biological need that kind of aesthetic need or any other purpose.
Thank you very much. So now getting into more technical details with the 5 minutes that we have left. One question that we received is when considering soft tissue thickness augmentation, what is your aim? How much are you aiming at gaining? 2 millimeters, 3 millimeters? How do you approach those decision-making algorithms?
Well, I think everything depends on the contour that you start. If you start with a very concave contour, because there's been a lot of time from the dental extraction and the patient has lost the buccal contour, then if you don't gain that contour with guided bone regeneration or with any lateral bone